It is a great honor for me to talk in the bone school and with all the stalwarts of pediatric hip with me. So I'm going to talk to you today about something which is very close to my heart, which is slipped capital femoral epiphysis. So what exactly is slipped capital femoral epiphysis? We know that it's an adolescent hip disorder where there is varus and posterior slippage of the capital femoral epiphysis. Now, to be frank, slipped capital femoral epiphysis or SCFE is something of a misnomer because usually the epiphysis remains more or less at the same place, but the metaphysis goes anteriorly and superiorly. So what I'm going to do is I'm going to go through 10 points of the management of slipped capital femoral epiphysis. And the first one is the most important, which is you have to diagnose it well. Why is it so important in SCFE? Because missed diagnosis is extremely common. The commonest scenario is an adolescent who is slightly overweight and comes with distal thigh and knee pain. And there are number of X-rays and MRIs and all those stuff done of the knee. But what is missed is getting an X-ray of the hip. So you can see that upstairs you have a slipped capital femoral epiphysis and that is missed. In fact, slipped capital femoral epiphysis is one of the commonest missed diagnosis in orthopedic litigations. Once you diagnose, you also have to diagnose the associated conditions. Now, associated conditions in this case are Down syndrome, hypothyroidism, Cushing syndrome, lupus, hypovitaminosis D is extremely common. So you have to get these checked before you embark on any surgical procedure. You have to get an endocrinologist usually involved in order to rule out these issues. We know what is the classification of slipped capital femoral epiphysis. Now there are three very important classifications, each with their own importance. The first one is what is known as the temporal classification. In temporal classification, it is basically a timing of the slip. Pre-slip is just a widening or irregularity of the physis. There is no definite time for this. But what is very important is to diagnose it, whether it is acute, chronic, or acute on chronic. Now, an acute slip is a slip which occurs with a history of less than 3 weeks. A chronic slip has a history of chronic hip pain of more than 3 weeks. While an acute on chronic hip is something which is very common, where the child has hip pain since a long time, more than 3 weeks, and suddenly falls down, has a small trip in the bathroom, and comes with an acute severe pain. So it's an acute on chronic slip. But the problem with this classification is that it does not predict the risk of AVN. What does predict the risk of AVN is this functional classification or the stability classification, which was described by Randall Loader way back in 1993. He divided slips into two types. One is stable slip, which is ability to bear weight, and unstable slips, unable to bear weight or able to bear weight with severe antalgia. Why is this important? Because stable slips have a very less risk of AVN, less than only about 1 to 2%, while unstable slips have an extremely high rate of AVN, almost 10 to 20, 60%, and in some series even more than that. We should know what is the severity classification, which is described by Southwick, which is mild, moderate, and severe. Mild is less than 30% of slippage, moderate is 30 to 50% of slippage, and severe is more than 50% of slippage. We should understand what is slipped capital femoral epiphysis. What is very important to know is that slipped capital femoral epiphysis is different than a traumatic Delbay type 1 fracture. A traumatic Delbay type 1 fracture has a severe slippage, but there are no secondary changes in the metaphysis and the epiphysis. In this case, it's a slow type 1 Salter-Harris injury, which is going through the proliferative and the hypertrophic zones of the physis. Here, the anterior periosteum is slowly stripped and the epiphysis goes medial, posteromedially, and there is severe rounding of the metaphysis. This proximal femoral metaphysis then starts impinging against the acetabulum, which causes cartilage and labral damage, and this has severely high risk of femoroacetabular impingement and further degenerative joint disease. Once you do that, we have to plan. Once to plan, we should know what are the case scenarios of slipped capital femoral epiphysis. So we'll go to two classic case scenarios in SCFE. One is a 15-year-old male has left hip pain since 3 months with no history of significant trauma and has mild pain and restriction of squatting. So you have a 15-year-old adolescent, slightly obese boy who doesn't have any other problems in activities of daily living and has come with mild hip pain with mild restriction of squatting and is able to sit cross-legged. So for all practical purposes, he is otherwise a normal child. And you can see that the left side is moving in an outward manner. So this is a typical out toeing gait. You can see that the foot progression angle in this case is almost 45 degrees. So this is a classic presentation of slipped capital femoral epiphysis, which is mild, which is out toeing gait. So any obese adolescent with out toeing gait, you have to look at the hip and you'll have to rule out an SCFE. Second is the child has an external rotation deformity. Usually in early slips, it's a mild external rotation deformity. And the child has a positive Dremon's sign. This is classic of SCFE, where the ipsilateral knee goes towards the ipsilateral shoulder. So this is because of the obligatory external rotation of that side. On X-rays, you can see one thing which you all many a time see is severe rarefaction and osteopenia, which is typically seen in hypovitaminosis D. And you can see the classic Klein's line sign. Now this is one line which is very important. You should draw a line on the superior border of the femoral neck. It should pass through at least some part of the epiphysis. This is a normal side. You can see that it is passing through some superior part of the epiphysis. As against that, in this case, you can see that the entire epiphysis is slipped down, and that is why the Klein's line is not intersecting any part of the epiphysis, and thus Klein's line sign is positive. The Southwick's angle is about 30 degrees, so it's about a 25 degrees of slippage. So this is a chronic, stable, mild slip. So you know you have to classify them, and we have to treat a chronic, stable, mild slip. I'll come to the treatment later on. So we should know, why do these X-ray findings lead to such great and clinical findings. So you have the proximal femur here, and if there is anything which is extremely important in the proximal femur, it is this blood supply which goes from the posterior aspect, as Dr. Rudra Prasad said, goes to the proximal femoral capital epiphysis. So whatever the treatment is done, we have to protect this blood supply. In slip, what happens is that the proximal femoral metaphysis goes anteriorly, the epiphysis goes slightly posteriorly, which is a chronic process with a lot of callus here. That leads to decrease in the internal rotation of the hip, and that leads to out-toeing of gait. So what happens when this similar hip pathology progresses further? What if happens when the SCFE progresses further? You have another child, is a slightly younger boy, a 12-year-old boy with left hip pain since 6 months, while right has pain since 3 months. He has gait abnormality which is increasing over time, and now he is unable to squat and has difficulty in sitting cross-legged. Now this is a very important finding. He has difficulty in normal activities of daily living. And you have this side. You can see that he has significant amount of Trendelenburg gait, significant waddling, and his external rotation is almost 60 degrees on both sides. The other thing which you look at when you see him walking from the side is that he is not flexing his hip much at all. It's almost like a robotic gait where he is moving almost only about 20 to 30 degrees of the hip, and not like the usual way the child should walk. So this is an out-toeing gait with a Trendelenburg gait. And you have the clinical finding of a severe external rotation deformity. On the left, it is almost 40 degrees, and on the right, it is 20 degrees. And what is very important is that flexion is restricted to only about 20 degrees on this side. The right side has a flexion of about 90 degrees, which is a slightly lesser involved hip. So the important thing is this. You can see this X-ray, he has a bilateral SCFE. The right side has a slip which is lesser, which is about 30 degrees to 20 degrees. the right side, the left side has a severe slippage. You can see that the slip is almost completely toppled down. So we should ask ourselves that why do these X-ray findings lead to such gait and clinical findings? So again, we come back to the same picture. The slip goes ahead, and here there are multiple phases of acuity where the slip goes ahead, and ahead, and then there is a lot of callus which is formed. As you can see here, the posterior vasculature becomes completely tightened here. There's a lot of callus which is sitting on the posterior vasculature, and this leads to severe external rotation. This then starts getting organized and leads to a severe deformity like this, and which, when articulating with the acetabulum, leads to severe impingement of flexion, leading to severe femoroacetabular impingement here. This causes restricted flexion. What causes the Trendelenburg gait? There is always some amount of proximal femoral overriding or the greater trochanteric overriding, which leads to shortening of the abductors, which leads to this Trendelenburg gait. Thus, this is the finding of a chronic, stable, severe slip. An unstable slip, as we know, does not, the child is unable to bear weight, so we cannot have a gait video of an unstable slip. So how do we treat an SCFE? What are the options? For that, we should know what are the goals of treatment. The first and foremost goal of treatment should be to prevent further slip progression. Once we do that, once we know this goal, that we should not allow the slip to progress further, the second is, if possible, restore for proximal femoral anatomy. Along with that, we should see to it that we should not cause AVN, so prevent the complications of AVN, and also prevent femoroacetabular impingement and degenerative joint disease. So these are the various options. We have in situ pinning, closed reduction, open reduction, safe surgical dislocation. We'll go to them one by one. So what exactly is in situ pinning? In situ pinning is exactly what the word means. That is, irrespective of the deformity or irrespective of the severity of the disease, you have to pin it in that position itself. This becomes extremely difficult in a severe slip or even a moderate slip, because if one has to go perfectly perpendicular to the slip, then it has to be a very anterior entry point, which becomes very difficult. The drill starts slipping, and if you go too anteriorly, there are the neurovascular bundles right here. There is a different technique where you can put an oblique screw, which was described by Dr. Prasad Gaurineni, where you can enter through the anterolateral cortex. You may not be absolutely central in the femoral neck, and you may not be absolutely perpendicular to the physis. That also can give rise to good results. This is in situ pinning. A clinical example where you can see it's a mild slip and it has been pinned in situ, and this usually leads to good results. It is a gold standard for mild to moderate slips. It is a percutaneous technique which has very less operative time and blood loss, and it prevents further slip from formation, from progressing. So that is the most important thing: prevent further slip progression. This is one of the landmark articles. The Iowa group had put forth this. It's a long-term study, almost 35 years of follow-up. You can see that this was the X-ray which they had put as a long-term good result. This is a 38-year follow-up. You can see they had shown it as a good result, but you can still see that there is significant amount of cam impingement in this X-ray. Do we put a single screw or a double screw? Well, a single well-placed 6.5 mm or a 7 mm screw without washer is enough for stable slips. Two screws may be necessary for unstable slips. However, biomechanically, both of them have been proved to be equivalent. Is there any role for contralateral pinning? The indications for contralateral pinning are these specific indications. One is if the child has endocrinological abnormalities. Second, if the child is very obese. The Western standard is about 35. Probably India, the BMI should be lesser, about 30 to 35. If the child has more than 2 years of growth left. So if you have a very young child, we should know that till the time he reaches skeletal maturity, he may have a higher chance of slippage of the other side. And lastly, unreliable follow-up. If the child is going to go away and he may not come back, it is better to pin the other side so that you are safer. Is there any role of closed reduction? So this was the photo in one of Monsetti's papers. usually most people don't utilize it. There are some Japanese papers who do utilize it. I do not have any experience about it. However, what is very important to know, is there any role for an acute close reduction, whether it is gentle, incidental, serendipitous? Usually this should not be done, because usually we are never gentle, we are always a bit forceful, and that leads to severe impairment of the posterior blood supply, and that can cause AVN. Is there a role of acute reduction and pinning? What does that mean? There's a very elegant method which was described by this man was known as Parsh, where you do a Watson-Jones approach and do an open reduction. But here you just pass a periosteum so that the slip is reduced to a level which is prior to the acute episode. So what does that mean? You have this slip, and it is a chronic slip which is there. So this is the child who is having hip pain since many days. Then suddenly he slips and then comes with an acute on chronic slip. In the Parsh method, you do a mini open capsulotomy, you put a periosteum anteriorly, and you reduce it to the level of chronicity. You should not attempt 100% reduction. You should make probably a grade 2 slip into a grade 1 slip, and then fix it with a screw. An example of an acute on chronic slip, you can see that there is a significant amount of posteromedial callus, which has been fixed with some amount of reduction. So it's a partial reduction with screw fixation. One of the other methods is an in situ pinning with an anterior burring with anterior osteochondroplasty. This decreases the amount of FAI which is possible. The jury is still out for this. We still don't know the exact efficacy of this method. Next, we come to more complex methods. So here we want to restore the proximal femoral anatomy. How do we do that? We go anteriorly. This is an anterior approach where you do a cuneiform osteotomy of the metaphysis. You remove as much as callus from the anterior aspect as possible. You cannot go to the posteromedial side. This leads to a significant amount of femoral neck shortening. You shorten the femoral neck and fix it with a screw. What is this approach? This is the cuneiform osteotomy, or the original Dunn osteotomy, which was described way back in the 1960s. In the earlier papers, this method had shown excellent results. However, in most other series, there is a very high, almost a 30 to 40% chance of avascular necrosis, and this could not be replicated by others. So what is the new treatment for severe SCFE, which is this, which was started with this great article, The Surgical Dislocation of the Adult Hip, followed by this article by Zibarth and Gans, where they combined the efficacy of the safe surgical dislocation approach with the Dunn subcapital realignment. So what does that mean? It's basically a Dunn osteotomy, which is performed through the safe surgical dislocation approach. It allows the restoration of the proximal femoral anatomy and prevents further slippage with the help of two things. One is an extensile retinacular flap, and second is the subperiosteal exposure of the femur for reduction and fixation. I'm just going to go briefly with that. What does that mean? You have a severe slip. You do something which is known as a trochanteric osteotomy. So it's a digastric osteotomy. You flip the trochanter anteriorly. You dislocate the femur anteriorly. So the entire proximal femur is out anteriorly. You release the entire proximal femoral blood supply. The retinacular flap is created so that this blood supply is completely intact by keeping this intact. You can remove the entire callus like this, reduce it well, fix it with one screw and 2 K-wires or with 2 screws, relocate the hip back and fix the trochanter. I'm just going to go through few case clinical pictures. You can see that this is the lateral approach which is used. This is the digastric flap. This is the greater trochanter, this is the vastus lateralis and the gluteus medius. So it has two bellies to this flap. So this is a digastric flap. The anterior capsulotomy is performed, and you can see that the entire proximal femur, the femoral head, is dislocated anteriorly. So this is the main problem area. You have a severe bump, and this is where what we should completely release. You can see that there is a big retinacular flap starting right here, going right down, and the osteotomy is marked right here. After which you can safely relocate the femoral head. You can see that the entire retinacular flap is completely intact and the proximal femur is subperiosteally released. All the while, you should see to it that the blood supply of the proximal femur is completely intact. You can see that it is bleeding, and that is the test that it is a vascular head that which you have left with. This is the post-operative X-ray of the same child with bilateral slips. This side has been fixed in situ, and this side has been fixed with safe surgical dislocation with a trochanteric osteotomy. You can see that the trochanter is distalized and fixed with 2 screws. This is 1 year follow-up. You can see that it has excellently healed. There is no AVN, and he has almost full range of motion. However, we should know that should be reserved usually for unstable slips, especially in the first few cases. It is an extremely technically demanding procedure, and you should have an operating staff who is familiar and prepared for the procedure. Should never go in the middle of the night to do this extremely demanding procedure. I was lucky enough to get a significant number of cases, and this is my study of 30 hips, which is probably the first in India. This is one of the X-rays which I had shown in the article. You can see that it's a severe slip. You can see a large amount of posteromedial callus. This is the same child after 3 years, showing excellent healing and no AVN. Thus, to reiterate, 10 tips: you should diagnose it well. See to it that an obese child with distal thigh pain should not be missed. The X-ray of the hip always has to be done. You should diagnose associated conditions. You should classify with the help of the 3 classifications. You should understand that it's a slow process. It's not a Delbey 1 fracture. We should know the goals of treatment. You should know the options. The in situ pinning is the treatment of choice for mild to moderate slips. The Parsh method should be done with care. You should do an acute reduction till the time of the chronicity. It should not be a complete reduction. Close reduction, or at least a vigorous close reduction, should be strictly avoided. And you should know the 2 complex methods, the Dunn method, which is done through the anterior approach, and know about the accurate and safe method, which is the Gans modified Dunn method. Thank you so much.